We have another excellent issue this month, beginning with a critically important article published in the New England Journal on the effects of semaglutide on chronic kidney disease in patients with type 2 diabetes, where we are going to be speaking with one of the authors of this article. Then, an article discussing the association between the burden of microvascular disease and cardiopulmonary fitness among adults with type 2 diabetes, published in Diabetes Care. Then we will discuss the association of metabolic syndrome with neuroimaging and cognitive outcomes, critically important, published in Diabetes Care. Then an article on tirzepatide for the treatment of obstructive sleep apnea and obesity, published in the New England Journal, where we will be talking with the first article of this paper. And finally, an article from Diabetes Care on semaglutide and cardiovascular outcomes by baseline A1C, as well as change in A1C, a sub-analysis of the SELECT trial. Our first article for this month is from the New England Journal of Medicine and is titled Effects of Semaglutide on Chronic Kidney Disease in Patients with Type 2 Diabetes, the FLOW study. This is a really important study, and joining us to discuss it is one of the authors, Dr. Richard Pratley. Dr. Pratley is the medical director at the Advent Health Diabetes Institute. He is senior investigator and diabetes program lead at the Translational Research Institute. Richard, welcome.
Thank you, Neil. It is an honor to be invited to be on your program, and it is really kind of an exciting time. So I'm really happy to be here.
It is exciting. And can you share with us the background for the study? Why was the study undertaken?
Well, sure. It's important to realize that chronic kidney disease is more common than most people might realize in patients with type 2 diabetes. About 40% would go on to develop some element of chronic kidney disease, not necessarily kidney failure where people are on dialysis. But it is still important because even those who have modest kidney impairment, a GFR below 45 or so, are at markedly increased risk for cardiovascular disease. So this identifies a very high risk population, and it's one that in the past we haven't really addressed very well. There have been studies, of course, of the ARBs many years ago, and those are part of our guideline-directed therapy. More recently, the SGLT2 inhibitors showed a benefit on slowing progression of chronic kidney disease. And then most recently, we have the nonsteroidal mineralocorticoid receptor antagonist finerenone, which also showed both a benefit on slowing progression of chronic kidney disease, but also a cardiovascular benefit. Why do we need another drug? And the answer is that there's still a substantial residual risk for both chronic kidney disease progression as well as cardiovascular disease in this very high risk population. We had indications from the previous cardiovascular outcome trials with the GLP-1 receptor agonist that there might be a benefit. So SUSTAIN 6, LEADER, Amplitude O, all suggested that there might be a slowing of decline in eGFR. But those studies were not powered to test kidney outcomes. And so we thought it would be really important to do a well-designed prospective study of a GLP-1 receptor agonist to test whether or not this entirely different class of medications, which we knew had benefits in patients with diabetes, could also have benefits in patients with type 2 diabetes and chronic kidney disease.
And it's such an important area. And I'm so glad that as we're talking about it, you're emphasizing the cardiovascular outcomes, because when I hear some of my colleagues talk about treatment of chronic kidney disease, they focus almost solely on that progression of kidney disease. But that other critically important endpoint is one that we all need to keep front of mind. Can you tell us about the methodology of the study?
Sure. Well, this study started many years ago. It was really designed in 2018, 2019. We initiated recruitment in this study. And this was designed as a randomized controlled trial, a placebo-controlled double-blind study, which compared 1 milligram of semaglutide to placebo on top of standard care. So we required that all patients be on maximally tolerated dose of RAS blockers, either ACE inhibitors or ARBs, to enter in the study. They had to have type 2 diabetes with an A1C less than 10%. And they also had to have chronic kidney disease, evidenced by a decrease in GFR and the presence of albuminuria. So we enrolled 3,530 patients in this study. Enrollment was doing really great, and then COVID hit. And it was a real challenge to stay on track. But as soon as the clinics were able to open up, we got back on track. We actually finished recruitment on time, which I think was an amazing accomplishment.
Yeah.
So the outcomes that we measured were primarily renal kidney outcomes. The primary outcome was a composite of kidney failure, defined as either needing renal replacement therapy, transplant, or dialysis, or a decrease in eGFR to less than 15 that was sustained, or a 50% decline in eGFR for kidney or CV death. And all of these are important components of the endpoint, but it's primarily a kidney endpoint-driven trial. We also had secondary endpoints that were tested in a hierarchical fashion. One was the slope of the decline in eGFR. The second was MACE, major adverse cardiovascular events. And the third was all-cause mortality. So we followed patients, and since this was an event-driven trial, we didn't know exactly how long the trial was going to last. Because of that, we put in an interim analysis. This was overseen, of course, by an independent DSMB who had access to the unblinded data. And at the first interim analysis, the DSMB recommended this trial stop early for efficacy. This is really pretty unusual. So we took their recommendation, and in January of this year, the last patient was seen. And the results are pretty remarkable.
So it's what we've all been waiting for. Tell us the results.
So for the primary outcome, which is kidney failure, kidney death, CV death, and the decline in eGFR, there was a 24% reduction in that outcome in patients treated with semaglutide compared to usual care. So that's a pretty substantial reduction in this endpoint. Then we moved on to the secondary endpoints, and what we saw was a slower rate of decline in eGFR, significantly so. And that was about 1.17 or something like that difference. And anything above 0.75 per year decline is considered significant. The second secondary endpoint was MACE, and we saw an 18% reduction in major adverse cardiovascular events. And then that allowed us to move on to the final endpoint, which was mortality. And there was a 20% reduction in mortality. So not only did we hit the primary outcome, but we hit significance in all three of the key secondary supportive outcomes. So not only was there a kidney benefit, but there was also a cardiovascular benefit and a mortality benefit.
That's pretty amazing. And it was a robust p-value. And we live in many ways in this abundance of riches. We have now medicines that, and I'm thinking primarily, we've known about ACEs and ARBs for a long time, but now the SGLT2s, finerenone, and now semaglutide, all of which have very important and significant effects on the renal endpoint and at least I guess not all of the SGLT2s, but some on the cardiovascular endpoints. And the challenge for us as clinicians then becomes how do we figure out who to use which medicine in, and any advice there? What are the clinical implications of this trial and some advice for us as clinicians?
Well, a couple of points. In the FLOW study, the study really started and recruited when the SGLT2 inhibitors were becoming standard of care. So only about 15% of patients were on SGLT2 inhibitors, and another 10 or 15% were added on during the trial. We don't have a big exposure to know about combination therapy. And then finerenone came even later, so there was almost nobody who was treated with finerenone. So we don't have the answer to how these drugs work in combination. What we do know, though, is that they're all working through completely different mechanisms of action. And the data that we do have with the SGLT2 inhibitors suggest that there is a benefit on cardiovascular endpoints and renal EGFR decline. So we think that the right thing to do is to offer all of these treatments to patients. Now, that seems like a huge lift. And you arguably, some people would start one medication for 3 months, start another medication for 3 months. If they're doing okay, start that third medication, then maybe start the fourth medication. Well, think about it. At that time, it's a year has passed, and we already saw a separation in the kidney and cardiovascular endpoints by a year. So you're exposing people to risk, potentially unnecessarily. But there is a paradigm whereby people are started on multiple medications to reduce risk. And that's people who are hospitalized with acute MI. They go in the hospital, they come out on 4 or 5 medications, all of which are evidence-based, all of which have been shown to reduce risk. And we don't think a second thing about it. That's just what it's done. And we're getting to that point in heart failure too. Certainly, if people are hospitalized with an exacerbation of heart failure, they come out on several medications that they weren't necessarily on. So I think we need to change our thinking about CKD in some way, which is people should have all of these 4 pillars of treatment that are evidence-based, and that they should be started early. And that is the way I believe we're going to decrease the risk for both CKD progression as well as CVD death and CVD cardiovascular disease and death in this very high-risk population.
Richard, thank you so much for putting that together, both the evidence and the wisdom about how to use the evidence. Dr. Richard Prattley, thank you so much for joining us.
My pleasure. Always a pleasure to be with you, Neil.
Our next article is from Diabetes Care and looked at the association between microvascular disease and cardiorespiratory fitness among adults with type 2 diabetes. So this was a study that looked at over 4,700 individuals who had either retinopathy, neuropathy, or nephropathy. They took all of them and gave them a cardiovascular fitness assessment test, and then they basically looked to see what percentage of people fell into a low cardiorespiratory fitness, and then kind of match that up with which of the comorbidities that they had. So for the patients who had no macrovascular disease, that was the reference number of 1 for an odds ratio. For people who had one of these complications, the odds ratio of having low cardiorespiratory fitness was 1.42. If you had 2 of these, it was 1.51. And if you had all 3 of these, your chance of having low cardiorespiratory fitness was 2.82. Neil?
John, we've talked many times on this podcast about the relationship between fitness and decreasing the risk of diabetes. We've talked many times about the relationship about higher levels of cardiorespiratory fitness and lower levels of subsequent heart disease or macrovascular disease. There actually isn't a lot of data out there on the relationship between cardiorespiratory fitness and microvascular disease, though it is not a surprise to see that, as this article so nicely points out, this is another benefit of cardiorespiratory fitness. I'm going to make this short and jump to my conclusion, which is here we have another reason, not just prevention and improvement of A1C in diabetes, not just decreasing macrovascular disease, coronary endpoints, but also a lower risk of microvascular disease, specifically neuropathy, retinopathy, and nephropathy. Our next article from Diabetes Care is titled The Association of Metabolic Syndrome with Neuroimaging and Cognitive Outcomes in the UK Biobank. The metabolic syndrome has been linked to dementia. In this study, the authors examined the association of metabolic syndrome with neuroimaging and cognition in dementia-free adults, looking to have some perspective on the impact of metabolic syndrome on brain health even prior to the diagnosis of dementia. To do so, they looked at over 37,000 dementia-free adults from the UK Biobank database. Metabolic syndrome was defined as having at least 3 of the following components: larger waist circumference, elevated levels of triglyceride, elevated blood pressure or A1C, or reduced HDL cholesterol levels. And the results showed that metabolic syndrome was associated with lower total brain gray matter and hippocampal volumes, as well as greater white matter hyperintensity volume. Study participants with metabolic syndrome performed more poorly on cognitive tests of working memory, verbal memory, processing speed, verbal and numeric reasoning, nonverbal reasoning, and tests of executive function. The more components of metabolic syndrome someone had, the less their brain volume and the poorer was the cognition across all domains. John?
So, Neil, metabolic syndrome, kind of the quintessential American disease, that 25% of U.S. adults, up to 50% of U.S. seniors. So certainly something that is very associated with kind of poor outcomes. There's a West of Scotland prevention study, and this study doesn't even look at LDL and actually showed that putting people on some statins can decrease cardiovascular outcomes. Now, this study that looks at cognitive decline and problems, we've talked on the show about diabetes being associated with a higher rate of cognitive decrease. The metabolic syndrome, for the most part, are things that are associated with excess weight. So when you look at elevated triglycerides, when you look at increased waist circumference, hypertension can all be part of this. So we spend as a nation $321 billion with a B dollars on people with dementia in the United States. Overall, for dementia care, it's about $72,000 per affected patient per year. So at some point, when we're looking at this, what would be the cost of figuring out some way to increase exercise, decrease weight? We certainly have a lot of exciting medications that have come out in the last few years. Does someone figure out that $321 billion, the number one expenditure for Medicaid in the United States is long-term care for seniors? At some point, does someone figure out the math and say, if we could lose X amount of weight in X amount of people, could we be saving money on the back end for not having to pay for long-term cognitive, just stewardship? We're not even kind of making a difference when we're taking care of people in nursing homes and improving their lot in life. It's really just for families to have someplace to give 24-hour care. So it will be interesting to see how this all plays itself out in the upcoming years.
Our next article is titled Tirzepatide for the Treatment of Obstructive Sleep Apnea and Obesity, the SURMOUNT OSA Trial. Joining us to discuss this article is the first author of the article, Dr. Atul Malhotra, Dr. Malhotra is a professor of pulmonary critical care and sleep medicine at UC San Diego Health and is a previous president of the American Thoracic Society. Welcome, Atul.
Thank you.
Atul, can you first tell us why this article was done, the background of doing this?
Yes, obstructive sleep apnea is a really common disease. We've estimated it affects up to 1 billion people worldwide. And that number is increasing, not decreasing, primarily because of the obesity pandemic. So body weight is a big factor in sleep apnea, and we know that losing weight can be helpful. We have good treatments for sleep apnea, such as CPAP, continuous positive airway pressure, where you pressurize the airway, but it's not for everybody. And when you look at it, it doesn't really do much to body weight. It can help control the sleep apnea, but it doesn't help with obesity or related metabolic consequences. So the idea of the SURMOUNT-OSA study was to treat the underlying obesity in 2 different studies. One, a group of individuals not using CPAP, and a group of individuals who were using CPAP. In both cases, we randomized to tirzepatide versus placebo to see whether the GLP-1 receptor agonist with GIP was better than placebo in terms of improving sleep apnea and related metabolic complications.
Okay. And for patients included in the trial, what degree of sleep apnea? Was this be with mild or?
We used an apnea-hypopnea index greater than 15 events per hour. So that's the number of cessations plus reductions in breathing per hour of sleep greater than 15. That's a breathing problem 1 every 4 minutes if you do the math. That's considered moderate to severe sleep apnea. Between 5 and 15 would be considered mild. We did not include those in this particular study.
Great, and that's helpful for us, our listeners to understand. And what did the study show?
The tirzepatide in both arms, in the non-CPAP arm, that's study 1, and in the CPAP arm, that's study 2. In both cases, tirzepatide was superior to placebo in terms of the primary outcome, which was the apnea-hypopnea index, the number of cessations plus reductions in breathing per hour of sleep. And in isolation, that's just a number. But perhaps more importantly is there were concomitant improvements in all of the secondary outcomes. And as a point of emphasis, all the secondary outcomes were pre-specified and all were controlled for multiple comparisons. So we saw marked improvements in body weight, in systolic blood pressure, in C-reactive protein, which is a cardiovascular risk marker, the so-called hypoxic burden, which is the degree, magnitude, and duration of hypoxia, and in patient-reported outcomes, which are also an important factor here. So we didn't just make the numbers look better, but the patients felt better.
Yeah, and if I remember correctly, the numbers didn't just look better, but there was not just statistically significant improvement, but it was an impressive degree of improvement.
Yeah, I was surprised at the magnitude of the improvement. For example, the systolic blood pressure got better by more than 9 millimeters of mercury, which I was quite surprised at the degree of improvement. Again, any of these numbers in isolation you could sort of ignore, but all of them happening concurrently in the context of marked improvement in sleep apnea as well, to me is quite reassuring. And so it was a pretty impressive change. The improvements of body weight were on the order of 18 to 20%, depending on which study arm you were in. So, just to contextualize that, if you start at 200 pounds, you'd come down 20%. That's 40 pounds. That's a big change from 200 pounds to 160. That would be one example.
It sure is. And that's consistent with the SURMOUNT-1 trial that we saw in obesity, where there was 21% or so body weight loss.
Let me comment on that if I may. So yeah, it was
Okay.
just over 22% that the Astropov saw in that prior New England Journal study. There was some discussion about where we're seeing slightly less weight change than in SURMOUNT-1. And the answer is maybe, but there's a couple of comments there. Number one is sleep apnea is a male predominant disease. And in prior obesity studies, it's female predominant because that's who ends up in bariatric clinics. And so we know that with GLP-1 receptor agonists, women lose more weight than men do. And so perhaps the slightly less improvement in body weight that we saw in SURMOUNT-OSA was perhaps because of the gender difference between SURMOUNT-OSA and SURMOUNT-1. The other factors are duration of follow-up was slightly less. And you can see the weights coming down further over time. And so that's another factor in terms of why we saw 18 to 20% rather than 22% changes in body weight. One other
And that-
factor worth emphasizing is that we excluded people with diabetes. We know that people with diabetes lose less weight than people without diabetes with GLP-1 receptor agonists. The SURMOUNT-2 study that was in the Lancet was in people with diabetes, and their weight loss was 13, 14%, much less than SURMOUNT-1 that had 22%.
Thanks for clarifying that. Now, there was an endpoint reported in Table 2 that I found particularly fascinating, and I was there at ADA when you and your group announced this result, and that was that the apnea-hypopnea index of less than 5, or an apnea-hypopnea index of 5 to 14 with an Epworth sleep score less than or equal to 10 at week 52. And it was pointed out that, and this is not something I would have known as a non-sleep specialist, but it was pointed out that it was relevant because those were the thresholds for disease severity that represent a level at which CPAP might not even be recommended. And in Table 2, it was somewhere around 40 to 50% in the first and second group, respectively, that reached that endpoint. I wonder your thoughts on that.
Correct. People throw around the word cured. And that's a word we use with some hesitation because for cured, it has to be a permanent fix that no longer requires treatment. And so cured is in the eyes of the beholder to some extent. I think there's a couple of comments there. Number one is an apnea-hypopnea index below 5 events per hour is considered normal. And in that context, continuing CPAP would be not indicated. And so there's no reason to treat that patient. Now, there's a possibility that they regain weight over time or things happen over time, but at least for the time being, if their apnea-hypopnea index is below 5, there's really no need for treatment. In the other cases where there's mild sleep apnea, apnea-hypopnea index between 5 and 14, with an Epworth sleepiness score less than 10, there it's a little bit debatable. Those are considered mild sleep apnea. Certainly one reason to treat them would be symptoms, that is an Epworth score greater than 10 or daytime sleepiness. But there's other reasons to treat those patients. Some are because they have hypertension. Some are because they have non-restorative sleep, or they're feeling groggy, or fatigue, or they're drinking 8 cups of coffee to stay awake and they're hanging out at Starbucks all day. So that's more of an individualized decision. So I'm hesitant to use the word cured in that context. We're certainly seeing marked improvements in sleep apnea, but clinically, I wouldn't necessarily withdraw CPAP on that patient with an apnea-hypopnea index of 12 if they still have hypertension or some other factor that I think I can improve with treatment.
That's great. Those are great points. So putting this all together, what do you see as the clinical implications for this study?
One thing that's important to emphasize is we did not do comparative effectiveness. We didn't compare CPAP and tirzepatide head-to-head because then we could say which treatment's better. That wasn't the goal here. The goal was to look at tirzepatide versus placebo in 2 different groups, a CPAP group and a non-CPAP group. And so the standard of care hasn't changed. It's still CPAP. And so what we know from the Cherno study in New England Journal 10 years ago is that if you treat either sleep apnea or obesity or both, the outcomes are best if you treat both sleep apnea and obesity, not either one alone. So the Cherno study looked at lipids and CRP and blood pressure and insulin sensitivity and all that. Treating both sleep apnea and obesity is better than treating either one alone. That hasn't changed. We just have a more effective treatment for obesity now that we have tirzepatide and other GLP-1 receptor agonists. And so the implications now, in terms of treating the whole patient, we think of diet, exercise, and sleep as the 3 pillars of health. With the dogma, if you ignore one, the other 2 will suffer. And so the standard of care for treating sleep apnea is still CPAP. If they cannot tolerate CPAP, then tirzepatide is a reasonable option. If they can tolerate CPAP, then tirzepatide may be a reasonable option to facilitate weight loss and improve metabolic risk.
Fantastic. It really seems like we are increasingly entering this era of co-management where we in primary care, you as a pulmonologist and sleep specialist, will be working together to hopefully give our patients optimal outcomes.
Yeah, if I could comment on that, if you think therapies are in competition, I think you're in the wrong business. It's a matter of treating the whole patient, offering what therapies are available to optimize their outcomes. The therapies aren't in competition. The doctors aren't in competition either. So if you're not working closely with your primary care docs, you're not doing your job.
This has been fantastic, Dr. Atul Malhotra. Thank you so much for joining us.
Thank you. Take care.
Our next article is from Diabetes Care and looked at semaglutide and cardiovascular outcomes by baseline A1C and change in A1C in people with overweight or obesity but without diabetes. This was the SELECT trial. So in this particular trial, it was a multi-center, double-blind, placebo-controlled trial of over 17,000 patients. The primary endpoint was time till first major adverse cardiovascular event, or MACE. The patients were randomized to receiving semaglutide weekly or placebo. Looking at the patients, the average age was around 61. 72% of the patients were male. Everyone had a A1C that fit below the diabetes threshold. So patients under 5.7 was about a third, 5.7 to 6 was about a third, and 6 to 6.5 was another third. So when they looked at all of this and looked at the two groups, everyone had an improvement in the time to the first MACE event, but there really wasn't a difference in the three groups. When they went out 20 weeks to see kind of the impact, the people whose A1C had the biggest delta, so people whose A1C was a decrease of 0.3 points, suddenly had a number that moved down to 0.55 from those other numbers that lived in about that 0.8 range. Neil?
John, this is a big deal. We know from a few years ago the SUSTAIN-6 trial of semaglutide in people with diabetes yielded a decrease in MACE. We know that's also true in people with diabetes. In the other CVOTs, a number of the GLP-1s achieved a decrease in MACE. But this is the first time we're seeing a GLP-1 show a decrease in MACE outcomes here in people with obesity without diabetes, all of whom had underlying atherosclerotic disease. And so the question was, is this only going to be true in people with prediabetes or the upper end of prediabetes? And it turns out it's true across the spectrum of A1C. This outcome, which was a remarkable outcome, over the roughly 3 years of the trial, there was a reduction of 20% in major adverse cardiac events in semaglutide versus placebo. This outcome was not related to a decrease in A1C, but had something to do with the pleiotropic effects of semaglutide. Now, I want to think for a minute about that 20% decrease in MACE and whether or not we think this is going to make its way to the standard of care. Let's just think for a moment about other medicines that we wouldn't think of not using. So cholesterol lowering for people with ASCVD. The original 4S trial of simvastatin showed a 30% reduction in MACE over 5 years. This was a 20% reduction over 3 years. The heart protection study, 20,000 people with ASCVD or diabetes, simvastatin showed a 24% reduction in MACE. And then the study treating to new targets, that was a Torva 80 versus 10, showed a 22% risk reduction in the higher intensity group, again, over 5 years. We would never think of not using a statin. It may be that semaglutide in people with obesity and atherosclerotic disease fit that same protocol. Let's just look briefly at aspirin for secondary prevention. Again, something that we don't think twice about. The antithrombotic trialist collaboration published in Lancet showed about a 20% decrease in MACE over about 5 years. A lot of different trials there. So the level of effect here is high. We are waiting to see what the guidelines show, but it sure seems like this is on the map now for people that you and I are seeing who are obese, who have underlying cardiac disease. I also suspect, John, that this is going to be something that we're going to be using. We may be the forefront of this in primary care. We are more used to using GLP-1s than our cardiology colleagues. I think this will be something that we're all going to need to think about a lot over the next period of time. For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.